السلام عليكم ورحمة الله جميعا، كيف حالكم؟ إن شاء الله طيبين، إن شاء الله جميع بخير إن شاء الله. نرحب بكم جميعا في إن شاء الله هذه المحاضرة الأولى الأرب بورد سيريس. الأرب بورد فيلوز إن شاء الله حيتولوا المحاضرات إن شاء الله، وتكون فيه محاضرات بإذن الله مرة في الشهر إن شاء الله. إحنا اخترنا محاضرات اللي هي حتكون لها علاقة بالجايد لاينز. اقرب جايد لاينز لليبيا هي الاوروبيان جايد لاينز، فقلنا حنشوف ان شاء الله باش ما تصيرش فيها يعني نوع من الديفيكولتيز وال يعني كونفيوجن. حتكون اليوروبيان سوسايتي اوف كارديولوجي جايد لاينز. نختار كل مره موضوع، مش حنقدر نغطوا كل شيء، لكن هنغطوا معظم المواضيع ان شاء الله. فالفيرست ESC guidelines will be about heart failure. حيكون البرزنتر ان شاء الله الدكتور اسامه بوزقيه. He's a second year Arab board fellow from مصراتة ميديكال سنتر. ان شاء الله حنكون المودريتور الدكتور عبد الغني بن نواره، البروجرام دايركتور الارب بورد كارديولوجي فيلوشيب من ليبيا. الاكسبيرت بانل ان شاء الله حيكون معنا الدكتور علي النيهوم ويل ديستنجوشد كارديولوجيست from بنغازي، الدكتور محمد الحراري distinguished cardiologist from ابو ظبي Emirates، والدكتور ايمن سمير distinguished cardiologist from Emirates as well. إن شاء الله يكون فيه ديسكشن بعد المحاضرة، ونفتح باب الأسئلة إن شاء الله. وإذا كان في أي حاجة أرجو أنكم تخلوها للديسكشن، جهزوا الأسئلة ونعطوا فرصة للإكسبيرت بانل إن شاء الله كل واحد يتكلم بعد المحاضرة إن شاء الله. الله يبارك فيكم، وإن شاء الله محاضرة قيمة للجميع. دكتور أسامة you have the floor إن شاء الله.
Thank you, Dr. Abdelghani. Thank you for your support in our board cardiology fellowship in Libya. Thanks for moderators, Dr. Ali Nahum, Dr. Ayman Smear, and Dr. Mohammed Harari. This is first lecture in our series about guideline, last European Society Cardiology guideline for diagnosis and treatment of acute and chronic heart failure. The last guideline, European guideline for heart failure, was in 2021. After that, there is updated guideline in 2023. No declaration of interest in this lecture. Well, we know that heart failure is one of the topics that has a lot of trials from 1985 for drugs that improve mortality and symptoms of heart failure. It started with ACE inhibitor, like in April in consensus trial in 1985. After that, beta blocker in 1995. Arabs trials about the Arab-like rails and Valheft started in 2000. After that, there is trials regarding CRTD rule and CRTP, like CARE, HF, Clinical Death and MADET CRT from 2005 starting. Very important trial about sacubicyl valsartan paradigm HF in 2015. After 2015, there is a lot of concentration about sodium glucose transporter co-inhibitors. And a trial is started with HFrEF like DABA HF and Emperor-reduced trials. And these trials all was before 31st March 2021. According to these trials, guideline in 2021 done. After that, there is amazing progress in heart failure trials from 2021 up to 2023, especially delivery trial and Emperor-preserved trial that confirm the role of SGLT2 inhibitors in improved prognosis and symptoms in HFpEF patients. Also, very important trial, strong HF trial, that is confirmed that benefit of starting early and rapid uptitration of guideline-directed medical therapy and their role in improvement in heart failure outcomes. Also, there is some trials like Iron Man trial, that is study the role of iron, intravenous iron, in improvement symptoms in heart failure, reduced ejection fraction patients. We'll start by definition of heart failure. Heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of cardinal symptoms like breathlessness, ankle swelling, and fatigue that may be accompanied by signs, elevated GVP, pulmonary crackles, and peripheral edema. So it is due to a structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest and or during exercise. According to the ejection fraction, heart failure classified to three types: heart failure, reduced ejection fraction when EF is 40% or less; heart failure, preserved ejection fraction when EF 50% or more; between 41 to 49 ejection fraction, this is heart failure, mildly reduced ejection fraction. The most important criteria for definition of heart failure is the presence of symptoms plus minus signs. In addition, in HFpEF criterion, there must be objective evidence of cardiac structural and or functional abnormalities consistent with the presence of LV diastolic dysfunction, raised LV filling pressures, including raised PNP or pro-BNP. This is not from European Society of Cardiology. This is a very important slide from American College of Cardiology and HA. Heart failure, that is classified heart failure to 4 stages: stage A, B, C, and D. Stage A, patients at high risk of heart failure but without structural heart disease, without symptoms of heart failure, like patients hypertensive, coronary disease, diabetic, but there is no structural heart disease by imaging and no symptoms of heart failure. This is stage A, patients at risk. If there is structural heart disease without symptoms, this is stage B, patients previous MI, LV systolic dysfunction, asymptomatic valvular disease, but without symptoms. This is stage B. If patient starting symptoms like dyspnea, orthopnea, ankle swelling, this is stage C, clinical heart failure. Stage G is refractory heart failure requiring specialized interventions like continuous intraop or mechanical support. All we know that when we will start by guideline, pharmacological treatment indicated in patients with heart failure, reduced ejection fraction. All we know the 4 pillars for HFrEF patients: ACE inhibitors, beta blockers, MRA, and SGLT2 inhibitors, dapagliflozin and empagliflozin, in addition to sacubitril valsartan. All of these medications are class 1A in patients with HFrEF. Other pharmacological treatments indicated in selected patients with HFrEF: loop diuretic is recommended in patients with HFrEF with sign and or symptom of congestion to alleviate heart failure symptoms, improve exercise capacity, and reduce heart failure hospitalizations. ARAB angiotensin receptor blockers is recommended to reduce the risk of heart failure hospitalization and death in symptomatic patients who are unable to tolerate an ACE inhibitor or ARNI. What about funny channel inhibitors, ivabradine? Ivabradine have a class 2A as in symptomatic patients with these criteria: LV ejection fraction 35% or less, must be in sinus rhythm, resting heart rate 70 beats per minute or more, despite treatment with an evidence-based dose of beta blocker or maximum tolerated dose below that, or patients who have contraindication to use beta blockers. What about soluble guanylate cyclase receptor stimulator? There is a quote, is a class B recommendation considered in patients with NIHA class 2, 3, 4 who have worsened heart failure despite guideline-directed medical therapy. Hydralazine and isosorbate dinitrate should be considered in self-identified Black patients with ejection fraction 35% or less, with a dilated left ventricle and NIHA class 3-4 despite treatment of ACE inhibitor, or as a class 2B if patients who are not tolerating ACE inhibitor or ARB. Digoxin is a class 2B in patients with HFrEF. This is a phenotypic approach to the management of heart failure reduced ejection fraction. For selected advanced heart failures, heart transplantation, mechanical support, and transplantation. To reduce heart failure hospitalization and improve quality of life for all patients, exercise rehabilitation is the class 1, and multi-professional disease management is class 1. If patients has aortic stenosis with HFrEF, SAVR or TAVI is a class 1. In case of mitral regurgitation, TE mitral valve repair is a class 2A. If heart rate in sinus rhythm more than 70, ivabradine class 2A. A black race, hydralazine, isosorbate dinitrate class 2A. ACE inhibitor, ARNI intolerance, ARAB is a class 1. What about devices? We will start by ICD, recommendation for an ICD patients in patients with heart failure. ICD recommended to reduce risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive for more than 1 year with good functional status as secondary prevention. The primary prevention, ICD recommended to reduce risk of sudden death in all-cause mortality in patients symptomatic heart failure, NIHA class 2, 3, and ischemic etiology, unless they have had MI in the prior 40 days and LV ejection fraction 35% or less despite 3 months or more GMD or OMT, provided they are expected to survive 1 year or more. The class 1A. The class 2A ICD should be considered to reduce risk of sudden death and all-cause mortality in patients with symptomatic class 2, 3 heart failure of non-ischemic etiology and ejection fraction 35% or less despite 3 months or more on optimal medical therapy, provided they are expected to survive more than 1 year. Class 3 ICD implantation is not recommended within 40 days of MI, as implantation at this time does not improve prognosis. Also, ICD not recommended in patients in NIHA class 4 with severe symptoms refractory to pharmacological therapy unless they are candidate for CRT, LVAD, or cardiac transplantation. What about CRT? Recommendations for CRT criteria: patient must be sinus rhythm, LV ejection fraction 35% or less, and QRS complex duration 150 milliseconds or more, despite patient on optimal medical therapy, maximal tolerated optimal medical therapy at least for 3 months. CRT should be considered for symptomatic patients with heart failure in sinus rhythm with the QRS duration 130 to 149, with left bundle branch block QRS morphology and LV ejection fraction 35% or less, despite optimal medical therapy in order to improve symptoms and reduce morbidity and mortality class 2A. What about right bundle branch block or non-left bundle branch block QRS morphology? If the QRS duration 150 milliseconds or more with non-left bundle QRS and sinus rhythm, ejection fraction 35% or less despite OMT, this is class 2A. CRT rather than RV pacing is recommended for patients with HFrEF regardless of NIHA class or QRS width who have an indication for ventricular pacing for high degree AV block in order to reduce morbidity. This includes patients with atrial fibrillation. The class 3 CRT is not recommended in patients with the QRS duration less than 130 milliseconds who do not have an indication for pacing due to high degree AV block. So, the key points of HFrEF treatment. A new class 1 recommended therapy for HFrEF is SGLT2 inhibitors, dapagliflozin and empagliflozin, in addition to other 4 pillars. The 4 key drug therapies should be initiated as quickly and safely as possible. Importance of tailored management. Primary prevention ICD in non-ischemic cardiomyopathy now is a class 2A. Emphasis on broad left bundle branch block in selected patients for CRT. Now we will talk about 2021 HFrEF therapeutic algorithm, management of patients with HFrEF. As we mentioned, for pillar S inhibitor, ARNI, beta blocker, MRA, SGLT2, and loop diuretic for fluid retention. All of these were class 1. If LV ejection fraction 35% or less and QRS less than 130 milliseconds, ICD. In ischemic is a class 1, in non-ischemic cause is a class 2A. If patient is sinus rhythm and ejection fraction 35 or less and the QRS duration 130 milliseconds or more, CRTD or P is a class 1 if duration more than 150 and class 2A if QRS between 130 and 149. If ejection fraction more than 35 or device therapy, if some symptoms persist, consider therapies with the class 2 recommendations like ivabradine and diuretics are recommended in patients with now we will go to heart failure, mildly reduced ejection fraction, EF between 41 to 49. In 2021, the class 1 recommendation is only diuretic with congestion to alleviate symptoms and signs. All others, like ACE inhibitor, ARAB, beta blocker, MRA, valsartan, sacubitril, were class 2B. What about heart failure preserved ejection fraction guideline in 2021? A class 1 screening for and treatment of etiologies and cardiovascular and non-cardiovascular comorbidities is recommended in patients with HFpEF, and diuretics are recommended in congested patients with HFpEF in order to alleviate symptoms and signs. No other medication to improve mortality. After that, we have 2 important trials. First of them is Emperor Preserve trial. That is compare empagliflozin versus placebo in heart failure mildly reduced and preserved ejection fraction in diabetic and non-diabetic patients. Sample of patients around 6,000, median age 72 years, 45% female, 51 of them atrial fibrillation and 49 diabetic. So half of the patients are non-diabetic. Follow-up for 26 months, primary endpoint, time to first event of adjuvant cardiovascular death or heart failure hospitalization. And no effect on cardiovascular mortality alone. So the trial revealed that is significant relative risk reduction, 21% of empagliflozin regarding to the placebo or compared to the placebo, and absolute risk reduction 3.3%. So a number need to treat 31. Delivery trial, that is testing dapagliflozin versus placebo, dapagliflozin 10 mg versus placebo. Patients, all of the patients in delivery trial, ejection fraction more than 40%, around 6,200 patients, follow-up 2.3 years. The primary outcome, 18% relative risk reduction, composite of worsened heart failure or cardiovascular death, a 21% relative risk reduction, and no effect on cardiovascular mortality alone. Also, there is improvement of symptom burden, and results were similar if ejection fraction more than 60% or less than 60%, and patients either diabetic or non-diabetic. So the effect of dapagliflozin across the range of ejection fraction is the same. If we see here, if ejection fraction 15% or 75%, the improvement of symptoms and improvement of mortality, cardiovascular death and heart failure hospitalization, comparing dapagliflozin with placebo is significant, regardless of ejection fraction. After these trials, heart failure might reduce ejection fraction update guideline in 2023. It stated that an SGLT2 inhibitor, dapagliflozin or empagliflozin, is recommended in patients with HFmrEF to reduce risk of heart failure hospitalization or cardiovascular death. So, in 2023 management of patients with HFmrEF, they are a class 1. Also, dapagliflozin, empagliflozin is a class 1. Other medications, ACE inhibitor, ARNI, MRA, beta blocker, are still a class 2B. HFpEF update guideline in 2023. SGLT2 inhibitor, DABA or EMBA, is recommended in patients with HFpEF to reduce risk of heart failure hospitalization or cardiovascular death, is a class 1A. So now, class 1A in HFpEF patients, diuretic, SGLT2 inhibitors, in addition to treatment for cardiovascular and non-cardiovascular comorbidities and exhaustion. So the updated recommendations for the prevention of heart failure. When we talk about the prevention, we talk about stage A, heart failure patients at risk. New recommendations for prevention of heart failure in patients with CKD and type 2 diabetes mellitus. 2 pharmacological treatments, SGLT2 inhibitors, in addition to finerenone. New recommendations for comorbidities about cardiovascular comorbidities, atrial fibrillation, chronic coronary syndrome, valvular heart disease, non-cardiovascular comorbidities like diabetes, iron deficiency, and cancer, and there are some special conditions in pregnancy, cardiomyopathies, myocarditis, and amyloidosis. What about management of atrial fibrillation in heart failure patients? Anticoagulation for prevention of embolic event is a class 1. The treatment of a trigger is also class 1, optimization heart failure therapy. If patient is hemodynamically unstable, so rhythm control is mandatory to return patient to sinus rhythm. After that, rhythm control by pulmonary vein ablation is a class 2A or amiodarone class 2B. Rate control by vein ablation and pacemaker is a class 2B. If hemodynamically stable, rate control class 2A and amiodarone or digoxin also class 2A. If symptom improvement, follow up. If not improvement, rhythm control by ablation, amiodarone or cardioversion is a class 2B. The new recommendations for myocardial revascularization in HFrEF and chronic coronary syndrome. There is a class 2A coronary revascularization should be considered to relieve persistent symptoms of angina or an angina equivalent in patients with HFrEF, chronic coronary syndrome, and coronary anatomy suitable for revascularization despite OMT, including anti-anginal drugs. The class 2B coronary revascularization may be considered to improve outcomes in patients with HFrEF, chronic coronary syndrome, and coronary anatomy suitable for revascularization after careful evaluation of the individual risk to benefit ratio, including coronary anatomy, comorbidity, life expectancy, and patients' perspectives. CABG should be considered as first choice revascularization strategy in patients suitable for surgery, especially if they have diabetes and for those with multivessel disease as class 2A. Management of secondary MR in HFrEF. Secondary or functional heart failure, mitral regurgitation in HFrEF patients is common. This condition need heart team discussion as a class 1. If patient need for coronary revascularization, if high surgical risk, PCI class 2B. If no high surgical risk, CABG and mitral valve surgery is a class 2A. If heart team decide about optimal medical therapy, including CRT if indicated, if persistent heart failure symptoms is still, so need heart team discussion. After that, maybe consider surgery in low risk or percutaneous end-to-end edge mitral valve repair class 2A. We have very important trial that's called co-opted trial that is give us some co-opted criteria to be present in the patient to decide for percutaneous mitral valve repair. All of the following criteria must be fulfilled: ejection fraction more than 20%, LV in systolic diameter less than 70 millimeter, systolic pulmonary pressure less than 70 millimeter mercury, absence of moderate or severe RV dysfunction or severe TR, and absence of hemodynamically instability. If these criteria fulfilled, percutaneous mitral valve repair is a class 2A. What about ESC 2021 heart failure guidelines in diabetic patients? SGLT2 inhibitors are recommended in patients with type 2 diabetes at risk of cardiovascular events to reduce hospitalizations for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death. SGLT2 inhibitors are recommended in patients with type 2 diabetic and HFrEF to reduce hospitalization for heart failure and cardiovascular death. The DKD method or study, that is study effect of finally known on chronic kidney disease outcomes in type 2 diabetic. Key inclusion criteria: type 2 diabetes, patients on ESC inhibitor or ARB maximum dose, and GFR 25 to 60 ml per minute per 1.73 square meter, urinary albumin to creatinine ratio 30 to 300, diabetic retinopathy or GFR 25 to 75. This trial revealed the role of finally known to improve outcome compared to placebo. So, new recommendations for prevention of heart failure in patients with type 2 diabetic and CKD, SGLT2 and finally known class 1A recommendation for these patients. New recommendations for iron deficiency anemia in heart failure patients, class 1, recommendation that all patients with heart failure be periodically screened for anemia and iron deficiency with full blood count, serum ferritin concentration, and transferrin saturation. The class 2A, intravenous iron supplementation with carboxymaltose should be considered in symptomatic heart failure patients recently hospitalized for heart failure and ejection fraction less than 50% and iron deficiency. Defined as serum ferritin less than 100 nanogram per ml or serum ferritin between 100 to 299 nanogram per ml with transferrin saturation less than 20% to reduce risk of heart failure hospitalization, and also to alleviate heart failure symptoms and improve exercise capacity and the quality of life. Recommendations for heart failure and cancer. Class 1C recommendation that cancer patients at increased risk of cardiotoxicity, defined by a history of risk factors for cardiovascular disease, previous cardiotoxicity, or exposure to cardiotoxic agents, undergo cardiovascular evaluation before scheduled anti-cancer therapy, preferably by cardiologists with experience or interest in cardio-oncology. A class 2A treatment with ACE inhibitor and beta blocker and preferably carvedilol should be considered in cancer patients developing LV systolic dysfunction, defined as 10% or more decrease in EF, and to a value lower than 50% during anthracycline chemotherapy. Most important, class 2A baseline risk assessment should be considered in all cancer patients scheduled to receive cancer treatment with potential to cause heart failure. Management of cardiac amyloidosis in heart failure. Tafamidis is recommended in patients with genetic testing proven hereditary HTTR, CA and NIHA class 1 or 2 symptoms to reduce symptoms, severe hospitalization and mortality. Tafamidis is recommended as a class 1 in patients with TTTR, CA and NIHA cardiac amyloidosis and NIHA class 1 or 2 symptoms to reduce symptoms, cardiovascular hospitalization and mortality. So the summary of new recommendations for acute heart failure patients. Trials are mentioned through no recommendations. There is ADVOR trial, IV acetozolamide 500 mg once daily or placebo added to IV loop diuretic. The primary endpoint of successful decongestion was achieved and p-value was significant. And neutral for hospitalization and or death and for adverse effects. We have other trial called chlorotic trial. This trial about oral hydrochlorothiazide in acute decompensated heart failure, 25 to 100 mg daily, depending on estimated GFR or placebo in addition to IV furosemide. A greater decrease body weight at 72 hours and similar change in dyspnea, a greater increase in serum creatinine. In Pulse trial, revealed that early initiation of empagliflozin, the primary endpoint defined as a clinical benefit, was achieved with empagliflozin compared with placebo in acute heart failure. Strong heart failure, this is very, very important trial. Lead to class 1B recommendation about an intensive strategy of initiation and rapid up titration of evidence-based treatment before discharge and during frequent and careful follow-up visits in the first 6 weeks. Following heart failure, hospitalization is recommended to reduce the risk of HF rehospitalization or death. Recommendations for management of patients after heart failure hospitalization. We have 3 recommendations as a class 1. It is recommended that patients hospitalized for heart failure be carefully evaluated to exclude persistent signs or congestion before discharge and to optimize oral treatment. It is recommended that evidence-based oral medical treatment be administered before discharge, and an early follow-up visit is recommended at 1 to 2 weeks after discharge to assess signs of congestion, drug tolerance, and start and or up titrate evidence-based therapy. The optimal GDMT recommendations despite the striking benefits. ACE inhibitor ARB-ARNI, MRA beta blocker, SGLT2 inhibitor. Up to 8.3 additional years free from cardiovascular death or hospital admissions for heart failure, up to 61% reduction in all-cause mortality comparing to conventional therapy. CHAMP heart failure trial revealed that only 1% of eligible patients were simultaneously treated with target doses of all ACE inhibitors, ARB-ARNI, beta blockers, and MRA therapy. Thank you for your attention.
Thank you, Dr. Osama. Fantastic talk. Well done, and I really appreciate the time you took to prepare for this. This is a very important topic. We have tons of patients who have heart failure, and we need definitely some guidance. Guidelines are to help us, to guide us, not really that we should all implement the same guidelines, but we should really follow them and try our best to stick to as much as we can guidelines to avoid any confusion and to give the best benefit and therapy to our patients. So thank you again, Dr. Osama, for the fantastic presentation. I'm going to open the floor for the expert panel. Before that, just going to request that please everybody stick to the time. So we'll open it for quick comment from every expert panel person, then answer the questions. The questions will be just for 1 or 2 minutes and to the point, please. And if anyone has a question, please raise your hand without interruption. There's a place where you can raise your hand, and I'll give you a chance, first come, first serve. There are a few questions written. I'm going to review them after we hear from the expert panel. So I'm going to start with Dr. Ali Naihoum, then Dr. Harari, then Dr. Smer. Please, your comment about the presentation, anything to add, then we'll open it for the questions. Dr. Ali.
Well, thank you, Dr. Abdul Ghani, for this nice organization, and thank you, Dr. Osama, for this comprehensive lecture about the guidelines for management of heart failure. I think the guideline is in the last maybe 10 years. It's very simplified nowadays to manage this kind of very important and very common disease. I mean, and as Dr. Osama said, that by application of this guideline-directed medical therapy, the evidence-based recommendation is that we can reduce heart failure mortality by more than 60%. This is, I think, the achievement have never been seen in any other medical disease. I mean, to reduce mortality by it reached up to 70% to reduce mortality by application of this evidence-based recommendations. It become very simplified to follow up a recommendation. And as Dr. Abdul Ghani said, the guideline is not a prescription. Treatments is different from patient to patient. You should have very high clinical sense to choose your patient, choose your medications. If you didn't apply this drugs in the recommended doses, recommended guidelines, mortality of this patient will be very high. It reach up to 50% in 5-year mortality. If we apply this guidelines, the mortality, as we said, that it will reduce, will hospitalization, which is a very poor prognostic factor even for this kind of patients. Every hospitalization will reduce life expectancy of this kind of patient. الحاجة اللي ننصح بها الأطباء زملائنا اللي هم حاليا في الكورسات هذينا انهم هم يعني يطبقوا المعايير هذينا ويعلموا الناس. يعني معظم الهارت فيلير patients they are dealt by physicians. They should talk to this physician. They should educate the physicians to manage this kind of patient in a very high standard of medication guideline directed medical therapy. Thank you, Dr. Osama, Dr. Abdul Ghani, for this nice presentation.
Thank you very much for the excellent comments, Dr. Ali. I totally agree with what you've said. I'm well aware of the time, so I'm going to move on for Dr. Harari, then Dr. Smer. Dr. Harari, you have the floor to say your comments about the presentation.
Yes, assalamu alaikum wa rahmatullahi wa barakatuh. Really excellent work, excellent program. I really commend it and support it. And great talk, Osama. Really, it's a big, difficult topic to cover. Really, I think you got more than 200, 300 pages to go through to do such a talk. I'll try to summarize a few things, really. Just for the HFrEF, the jury is sorted, really. You've got the 4 pillars, the SGLT2 inhibitors, the beta blockers, the MRA, the ACE, and ARNI. And the point is not you have to give them, obviously, but only the importance of early initiation, quick rapid titration to the target dose. That's very important. You got the 4 pillars for all unless the reason not to, you cannot tailor to patients. The other therapy, the other combination, we should not ignore them. Very important. Revascularization. Somebody who require revascularization need to be revascularized. Those with valvular heart disease, particularly aortic stenosis, should be sorted. The mitral regurgitation we talked about for this functional MR after maximum therapy. Device is covered, but it stressed the importance of your ICD for those with ejection fraction less than 35%, particularly the ischemic heart disease, ischemic cardiomyopathy. The non-ischemic rule is this clear, but it's class 2A rather than class 1. For the CRT, the best people who benefit are those with left band punch block more than 150 milliseconds. The lower, the narrower the QRS, the less the benefit. The non-left band branch, the less the benefit. Important is the point that Osama mentioned. Those who with HFrEF who requires pacing for high degree AV block, regardless of symptoms, should be considered for CRT rather than standard pacing. Role of comorbidities, you mentioned the correction of iron deficiency, not anemia, iron deficiency for symptomatic control and reduction of hospitalization. Quick word about the HFmrEF, the one in the group in the middle. Really, the recommendation is very similar to HFrEF, but just class recommendation becomes less for the MRI, the beta blockers, and the ARNI, while it remains class 1 for SGLT2 inhibitors. Then moving on to the HFpEF, which is now the new thing. This is the big change in 2023 with the DABA, the DELIVER, and the EMBRA-Preserve. Now class 1 recommendation to give these drugs, but not to forget to treat comorbidity, revascularization, hypertension, whatever. This is also class 1 recommendation, and also diuretic for those who are overloaded. The European do not consider other therapy, which are considered by the American as class 2B, which are the MRA, the ARNI, and the ARB. Beta blockers has no role in treatment of HFpEF unless they are given for other reasons. The other one, just before I finish, in acute heart failure, I know there was no like a new dramatic recommendation, except the strategy is now big emphasis, and actually it's class 1 recommendation that you have to treat these people in acute heart failure to start guideline-directed therapy during hospitalization, and actually even up titrate to the target dose as much as you can, even during hospitalization, not only just after discharge. So change in the recommendation regarding strategy rather than actually new therapy, even though that's still the ADVOR did favor the use of STFZMI, but it was not in the recommendation. Before I finish, prevention of heart failure. Prevention of heart failure, now we can prevent it. In diabetic with CKD proteinuria, if you give them SGLT2 inhibitors, if you give them finerenone, you stop them getting into heart failure. And I think I will stop there. Thank you.
Thank you very much, Dr. Mohammed. Excellent points. We'll summarize and appreciate the time to prepare for those points. They're really helpful. Dr. Ayman Smair, you have the floor to say your comments about the presentation.
السلام عليكم ورحمة الله وبركاته. شكرا على الاستضافة وأحسنت دكتور أسامة. Excellent presentation. Wonderful comment from Dr. Ali, Dr. Mohammed. It's hard to add on their comment, but one thing I thought of is to give some perspective to compare the 2023 ESC guidelines to the American 2022 guidelines, because it's similar. So I'm going to talk about relevant point and similarity and some differences. I think the emphasis was on the 3 categories: HFrEF, HFpEF, and heart failure with the mildly reduced. In the American guidelines, they use the same category, 3 category: heart failure with residual fraction less than 40%, 40 or less; heart failure with the preserve 50 or more; and that the mid-range we called mildly reduced from 41 to 49%. But they also, for the American guidelines, the 2022, they add the category of the heart failure with improved ejection fraction, and they kind of They put it under the heart failure with the mildly reduced. So those are the patients that they have a low EF, that then their EF improve to more than 40%. That was not included in the European guidelines. And actually, there's a movement and push in the heart failure field to move from 3-category heart failure into 2 categories. So they want to use, for example, actually not example, the idea is to use heart failure with normal ejection fraction, called HFnEF. Those are patients with heart failure with EF 60% or more, because there is no specific therapy proven for those except for SGLT inhibitor. And then HFrEF, and they use less than 60%, as you know, because the interest to ARNI trial, there's recent trial that showed some patient with the mid-range to low in the 50, they did benefit from ARNI in those patients. But the guidelines end up staying with the 3 category of HFrEF, HF mild reduced, and HFpEF. So this is one main change. The other thing for the medication-wise, SGLT2 inhibitor, it's a class 1 indication in the European guidelines. Based on that, I have heart failure and emperor preserved. The American guidelines give it class 2, still indicated across the board in all types of heart failure. HFrEF, mild reduced, and preserved. SGLT inhibitor should be on any patient with heart failure, regardless of the ejection fraction. The European, they give it more weight than the American, but I think with more, and the reason for that, this trial, the emperor preserve, came in at the end of 2022. So after the American guidelines were out, so I'm expecting with the new update for the American guidelines, also they will upgrade SGLT inhibitor to be class 1 indication. As you know, for people not familiar with the class 1, you should, class 2A, you would, class 2B, you could, class 3, don't do, harmful. So these are things, make sure you remember in your practice. You always want to stay in class 1 and class 1 2A, like you should and you could. In certain situation, you could use some of these medication that Osama nicely highlight, like for example, evabradine, in those cases that you could consider another medication. The other things, and Muhammad Al-Harari mentioned on that, the European guidelines, they have a clear emphasis on prevention of heart failure. And actually, they mentioned that the use of SGLT2 inhibitor in patients with diabetes and CKD should be started to prevent heart failure. The American guidelines did not mention specifically on the prevention of heart failure. We're just talking about risk factor modification. So that's another plus and advantage of the European guidelines, to specifically focus on prevention for heart failure. And they give a weight and recommendation to use the SGLT inhibitor in patients with CKD and diabetes to prevent the progression of CKD and also heart failure. The other thing, and I'm glad that Osama pointed out the strong heart failure trial, and I met the principal investigator, Dr. Mebaza, me and Dr. Osama, Dr. Ali, and Dr. Zaki. We met him in the recent Tunisian cardiac guidelines. So the strong heart failure trial is a clinical trial, very important. It was published back in 2022, and the European guidelines, they jump on it. They took it because it's like Osama showed us, showed significant improvement in those patients. And this is an emphasis from European guidelines that early initiation of guidelines therapy before discharge, your patient should be on the quad therapy, should be on the appropriate beta blocker, the ARNI ideally. If not available, you can use ARB or ACE, MRA, the spironolactone, or now recently finerenone, and also the SGLT inhibitor. And they should start before discharge with early follow-up in the 6 week, because this patient obviously did much, much better compared to the routine care. So this is the American guidelines. They just emphasis on the stabilizing those patients with acute heart failure. They didn't mention much about the initiation of this therapy before discharge. So this is another last point I would like to mention, which is another plus and advantage of European guidelines, the 2023. They did highlight clearly in the guidelines the use of GLP-1 receptor agonists, like the newer medication like Mounjaro and Victoza. Mounjaro and Ozempic, mainly used for weight loss. And as you guys know, recently there was a recent trial, the STEP heart failure and summit trial, and showed clearly that this medication, it did improve patient with HFpEF and obesity. So that was also mentioned in the guidelines, not directly, but they can recommend use the medication to help the obesity in patients with heart failure to have an outcome. And I'm sure that with the newer guidelines, this medication will get approved as heart failure medication. As you know, SG inhibitor initially start as diabetic medication, and now with cardiology we stole it and we start using. I think the same thing will be for GLP-1 receptor antagonist. I'm gonna end here, and sorry for taking long.
Thank you very much, Dr. Ayman Smer, for these excellent points. I totally agree. They're very helpful. I'm going to say a few comments, then I'm going to open it for the questions. We'll start with the questions written on the chat box. Then anyone has a question, please raise your hands. My comments about this is always we have to follow the guidelines for the 4 pillars. So four medications you have to start, as Dr. Sam mentioned, clearly in the guidelines we all know. And don't forget loop diuretics titration, very important. Patient's symptoms, we don't have strong evidence to support Lasix or loop diuretics therapy as a mortality benefit, but I don't think anybody will dare to do any trial to compare Lasix with placebo in patients like heart failure, pulmonary edema, for example. So loop diuretics are important. Use them according to the patient's response, patient's body weight, close monitoring of the patient's renal function, sodium, potassium, body weight. Very important to follow the patient's body weight. It helps with titration of therapy. Blood pressure, very important to see if the blood pressure is controlled or low. According to that, you titrate the therapy. Heart rate, for example, if you want to add ivabradine, you need to know the heart rate. ECG, if the patient has diff bundle or not. And ejection fraction, so repeat the echo according to the guidelines, if needed in 1 month or if needed in 3 months. I have seen many patients being followed for a long time with low ejection fraction without either titration therapy or adding the device if needed. Look for triggers. If the patient comes back with decompensated heart failure, why he came back or she came back? Is it because of lack of therapy, because of non-compliance with fluid restriction, salt restriction? Is it because of new arrhythmia or ischemia, etc.? So you have to look for the reason, not only to treat the heart failure and send the patient home. Also, timing for devices, ICD versus CRTD, and the timing for that. For CRTD versus CRTP pacing, I always caution people to be careful and think twice before putting CRTP, because if the patient has low ejection fraction and you put CRTP, you deny the patient from the shocking benefit of the ICD. So always consider CRTD defibrillator if indicated. Revascularization if needed. We know it's class 1 indication for both BCI and CABG. Remember, it's not only BCI. People always think about BCI, but it's also for CABG. If the patient needs revascularization, it's class 2A, but should be done if necessary for selected patients. Non-pharmacological therapy, always educate the patient, especially for salt low diet, for fluid restriction, regular follow-ups, cardiac rehabilitation. These things have to be considered always to make sure that patients get the best benefit of our therapy and you get the improvement they need. And thank you very much for your attention. Open it for the questions now to answer. If anybody has a question, please raise your hands. First question was about SGLT2 inhibitors in mid-range heart failure. That was answered, but I'm going to quickly, if you don't mind, Dr. Ali Nahum, to answer that quickly, only a couple of words. Dr. Ali, do you hear me?
Can you repeat the question, please?
Oh, yeah, SGLT2 inhibitors in mid-range heart failure.
Yes, nowadays, I mean, after this recent studies, it is a class 1A recommendation for mid-range heart failure. I mean, whether you say DABA or empagliflozins.
No doubt, no doubt. Thank you very much,
no
Dr. Ali. Dr. Ali Al-Harari, Dr. Muhammad Al-Harari, please, question number 2 about the role of coronary artery disease evaluation in heart failure patients. What is the rule and how would you do it?
It's a class 1 recommendation really, that you evaluate your patient for a possibility of underlying coronary artery disease by symptoms by non-invasive investigation, and if required by non-invasive investigation. Revascularization plays an important role, both in HFrEF and HFpEF is a class 1 recommendation, and those with vascular disease and impaired function, probably cabbage will actually be preferable to BCI.
Thank you very much. Next question, what is the appropriate time for intervention, PCI and HFrEF with ejection fraction less than 30%? Any precautions, Dr. Ayman Smer?
No, not really. And like what not really. And like what Dr. Muhammad says, when you have those patients with the ischemic cardiomyopathy and newly diagnosed HFrEF, it's not in the setting of ACS. I need to make sure I'm clear. I'm not talking about patients presented with ACS like anterior STEMI, now have a low EF. We're talking about those chronic patients who found to have cardiomyopathy ischemic, low EF. You do an ischemia evaluation, you find this disease. The preferred revascularization strategy, it's CABG, complete revascularization, and that's based on the STITCH trial. This is the main randomized trial we have, and showed that patient with CABG, they have better outcome, 10 years data over medical therapy. PCI, and unfortunately, did not show a good result. Revive trial, that was a recent trial, did not show significant progress. Yes, we still do it in certain situation, but the guidelines recommendation, if your patient have ischemic cardiomyopathy and they're candidate for revascularization, the CABG is the way to go.
If you can answer the question about acute decompensation of heart failure with low ejection fraction, time for Entresto initiation. That's first part.
I mean, after stabilization of this patient and the use of diuretics and decongestions, I mean, if there is a chance to start Entresto before patient discharge, you should start it. This is a class 1A recommendation, so it should be started before discharge. If patient
what time, Dr. Ali, is like a patient admitted now with decompensated heart failure, do you start at the same day or wait a little bit?
No, I mean, when the patient will be decongested and symptomatic improvement with diuretics in the first few days, for example. Some patients, they may need 3 to 4 days. Some patients, they may need a week or so to start. But before discharge, this patient, you should start all الفور بيلر اللي قلنا عليهن منها الانترستو إذا كان في possibility إن it's recommended over an ACE inhibitor or ARB. So you should start up titration of these drugs. As we mentioned, within 6 weeks, you should have a maximum dose of Entresto.
Dr. Ali, if the patient has renal failure, mild renal failure, how would you manage?
Yes, renal failure. This is a big problem. I mean, we should carefully follow up the patient with renal failure. If we start with them this medications, and they need more close observation and follow up. Yes.
Yeah, and it helps renal failure. So there's clear evidence that Entresto actually helps renal failure. Yes. Excellent. Thank you, Dr. Ali. Dr. Mohammed Al-Harali, role of antiarrhythmic drugs in AFib with heart failure with reduced ejection fraction. What's the antiarrhythmics versus rate control in heart failure?
Yeah, just quick comment on just to add to what Dr. Ali Mohammed said. Just support, by the way, we have tried to support the inpatient use, the Pioneer trial. You compare not only Entresto versus an active comparator, enalapril, as an inpatient, and shows a reduction in everything really, outcome. And also we have the Impulse trial, which used the SGLT inhibitors as soon as the patient actually off inotropes, off if needed be, or off vasodilator. As soon actually you don't, even if they're still on IV diuretic, as long as you don't need to titrate, you can start. So early, very, very important emphasis on the early initiation and up titration. As far as the antiarrhythmics, so for AF, you can try, if in UF heart failure, you can try rate control, even with beta blockers only, without antiarrhythmic. If the patient is absolutely fine, the likelihood that they won't be, and there is a class 2A recommendation to try, for example, drugs like amyloidosis. But really, for me, the push is for rhythm control for this patient. And for those actually BVI, so pulmonary vein isolation, is a class 2A recommendation to use. Actually, probably now it's in the AF guidelines class become class 1 recommendation. So your aim, because losing the atrial component, which is 25% of the cardiac output, you lost it if you go into AF. Patients really deteriorate quickly, whether HFpEF or even HFrEF, if you go into AF. So your aim should be rhythm control. An idea, I would say, by ablation, but if you can't, by rhythm control, by antiarrhythmics. So there's a big role for use of antiarrhythmic, yes.
Well, thank you very much, Dr. Muhammad. I would add, most of those patients, they actually get heart failure from their AFib. So if actually you just do cardioversion, you get them out of heart failure, the ejection fraction improve. So consider cardioversion, consider anticoagulation, antiarrhythmics. Rate control is really good because it's safer, but antiarrhythmics and consider.
I lost Abdul Ghani. Is it just me?
We lost you, Abdul Ghani.
Okay. طيب until Abdul Ghani is back, Muhammad, and I just want to emphasize the point you just mentioned regarding rhythm control, maintenance sinus rhythm. There's actually two trials, CAST-AFib, CASTLE-AFib, والCASTLE heart failure. CASTLE-AFib published 2018, and I even did meta-analysis on it. والCASTLE heart failure showed AFib ablation patient with heart failure, ejection fraction have better outcome. الCASTLE AFib, they also compare ablation versus amiodarone. The ablation was superior. الCASTLE heart failure was mainly focusing on the ablation was superior. Maintaining sinus rhythm is the way to go in those patients.
Like what sorry.
Yeah, well, like what Abdul Ghani said, إنه يعني at least when you don't have much resources, try to achieve sinus rhythm, cardioversion, of course, after appropriate anticoagulation and DE or TO to make sure there's no thrombus is very reasonable approach.
But also his point about what he didn't specifically mention is tachycardiomyopathy, which is really, we don't leave the patient running fast, whether it's the F, because that will make them worse. It may even induce heart cardiomyopathy. So the minimum you do is really good rate control, but you aim for rhythm control by whatever means.
Yes.
I think Abdul Ghani is not back.
Abdul Ghani. Osama.
Dr. Ayman.
Well, I can ask you a huge favor. Can you go back to that slide that showed the class 2A for the CABG and 2B for the PCI for the record بس.
Yes.
على الأقل أسامة على الأقل عبد الغني when he come back عبد الغني come back find
يزعل عبد الغني. لا عبد الغني خلاص موجود.
عبد الغني are you back؟ عبد الغني.
Not back.
Take over.
For the record, CABG 2A based on stitch, PCI 2B. One. You don't have to be interventional cardiologist to know this.
This one.
Yeah. That's it.
خلاص.
Yeah.
عبد الغني لحظة بس. خلينا put him back as co-host.
ايوه السلام عليكم تسمعوا فيا؟
السلام.
سوري اني lost the connection باي ميوتد بي ايمن انت خليتني ميوتد.
لا انا تشينج تو كو-هوست تو. لا
تمام بارك الله فيك. خلاص دكتور محمد انا سمعت الكومنتس بتاعك انت والدكتور ايمن بارك الله فيكم. بالنسبه اللي انت اسمها البي سي اي والريفاسكولايزيشن يعني ممكن اشوفها اقراها لنا دكتور وسام بوزقيه. دكتور اسامه اقرا الريفاسكولايزيشن هنا الجايد لاينز شنو تقول؟
This is a recommendation about revascularization in patients with HFrEF and chronic coronary syndrome. Recommendation CABG should be considered as first choice revascularization strategy in patients suitable for surgery, especially if they have diabetes and for those with multivessel disease, class 2A. PCI may be considered as a class 2B as an alternative to CABG based on heart team evaluation, considering coronary anatomy, comorbidity, and surgical risk.
اقرا الثانيه اللي على اليسار يا دكتور اسامه.
على السايد the class 2A in the coronary revascularization considered to relieve persistent symptoms of angina or angina equivalent as a class 2A. The class 2B considered revascularization to improve outcome in patients with HFrEF, CCS, and coronary anatomy suitable for revascularization.
بالضبط. So it's class 2A, class 2A both, but you consider patient suitability, patient diabetic, coronary anatomy. هذا اللي قلته انا من بكري يا دكتور ايمن. ما اعرفش انت شنو كومنت صح. الترايلز خليهم على جنب، احنا نكلموا الجايد لاينز. الناس هنا بتسمع عشان تقول لنا الجايد لاينز، لان في هلبة ما تعرفش الترايلز اللي تعرفها انت ونعرفها انا. لكن احنا بنتبع الجايد لاينز عشان تقول لنا سيلكت البيشنت، بيشنت يحتاج بي سي اي دير له بي سي اي. خلي البيشنت سنترد كير هو الاهم، مش الفيزيشنز what the physician wants. It's about what can be done, what should be done, not what can be done. What should be done? What can be done? Yes, we can do BCI to everybody, but does that really should be done for the patient? No. So we have to select our patients. Is it acute coronary syndrome versus stable? This is for stable CADs, class 2A, cabbage, and PCI for selected patient. Is it diabetic, not diabetic, etc. ثاني دكتور أيمن. دكتور أيمن عندك
نعم.
الفلور. You have the floor if you want to say your comment.
لا خلاص I think it's very clear 2A for cabbage 2B for PCI revascularization in general. If patient symptomatic in terms of have angina, you suspect ischemia, this is what you would and they should do when you talk about your choice for revascularization. Cabbage, like I said, because based on Stitch big trial, you also can consider PCI. So 2B doesn't mean you don't do it. Like you said, it depends on the circumstances, but just that to me the guidelines is very clear. Now, if you see they give 2A when they have persistent symptoms of angina, that means they're symptomatic in terms of ischemia. And they give 2B because they're actually the main advantage that showed by the Stitch that they live longer. In terms of the EF improvement did not show much in those trials. And I'm sure in the future there's more data to show. I like what you said about this is not ACS. This is not a patient who presented with ACS. This is a different patient, chronic ischemic cardiomyopathy patient. Thank you.
And remember, with the advances in interventions and techniques for intervention, the outcomes will improve, I'm pretty sure, because we see it in our patients. I see it personally in my patients. It's a huge difference. I'm really surprised with the results of those trials, because you see patients come with ejection fraction. It's a selected patient. We can't compare our patients like simply because we can't do trials, but it's about the outcomes, and I'm pretty sure in the outcomes in the future we'll have more evidence to support that and to support the use of PCI for certain patients. Cabbage, especially lima. Remember, cabbage you have to have lima. If there is no lima, no cabbage. دكتور أيمن بالله I lost the rest of the questions.
المسجز
يا ريت تشوفهم لي ونبي. Anybody has a question? Can you raise your hands, guys, if there is anyone has a question?
خلاص لحظة go over the
بنسأل
question.
الدكتور محمد الحراري. دكتور محمد بنسألك أنا على CRTD versus CRTB. أنا I planned CRTB, but most of my patients I bought CRTD because I want them to get the benefit of the shock of the ICD for sudden death prevention. When do you consider CRTB?
Okay, I mean the guidelines I think are clear really. So a patient has to have a HFrEF less than 35%. You have to have they have to be for the CRT part of it had to be on maximum therapy of at least 3 months. You have to have a life expectancy for at least 1 year. For the ICD itself, they should not. Again, it's very important. We don't do it within 40 days of myocardial infarction. And again, they should not be in class 4 heart failure and put an ICD on them. So they're separate. For the CRTB versus CRTD, I think there's the Danish trial showed in non-ischemic cardiomyopathy there's no superiority really. So actually, the recommendation now, that's why it's been downgraded. The CRTD has been downgraded to class 2A rather than class 1 for non-ischemic cardiomyopathy. The non-ischemic cardiomyopathy, the recommendation is weaker because they found that even putting CRTB itself does reduce mortality, and if one patient actually would not need to be shocked. But the ischemic cardiomyopathy, those with the scar, the ischemic cardiomyopathy, the ICD is very strong. They have to have an ICD really. whether without CRT depends on the QRS.
Yeah, Dr.
Right.
Mohammed, age limit. What's your age limit for patients? I have patients come to me in the 80s. My cutoff was 85, but I feel it's really old patient. That's 1 or 2 patients only because they really wanted it. They are very good, but what's the cutoff age?
Guidelines does not mention age. Age is a number. So as long as they have
Yeah.
they're going to live good quality of life for more than a year, yes. ICD is
Exactly, yeah, that's the point. So look at select your patients quality. I mean, if the patients sometimes 90 they look like 70, sometimes 70 they look like 90. But obviously we have to be realistic. I mean, if they come above 80, we have to be really careful and say, really you need it. But if it's 50 or 60, we don't even ask that question. I mean, if it's clearly indicated, we should put it. Especially it's very expensive device. It's for selected patients and it's limited. It's not like available for everybody readily like pacemaker.
Yeah, the guy says also
Dr.
عبد الغني في excellent question.
Dr.
انت want me to go over the question صح? You don't see them. في excellent question.
Yeah, please go.
Excellent question from Dr. Abdu كاتب when to stop medication if EF recovered of patient with history of heart failure with reduced ejection fraction HFrEF. Excellent question.
Dr. Ali Nahum, please. When to stop the medications? Patient has low ejection fraction, now improved with medical therapy. Normal ejection fraction, when to stop it?
يعني ممكن دكتور محمد عبده هو اللي يجاوبنا على السؤال هذا. محمود.
لا مش محمود. لا محمود مش معنا، ما قدرش يجي هو للاسف.
مش محمود، مش معنا. اوكي.
لا مش محمود. It's not a tricky question, دكتور علي. لا.
Okay. This is very nice question. I mean, this is زي ما قال الدكتور ايمن فيه الريكفري هارت فيلير تو في الامريكان American guidelines في recovery heart failure. فأعتقد it will be different from patient to patients. I mean, if you follow your patients, I mean, you can if you are sure that this patient have completely recovered, you can I mean down titrate the medication. I think it's like this, but I don't have any study which supporting that. If Ayman or Muhammad Al-Harari have some comments.
Well, last but no, my opinion from what I heard is you shouldn't stop it. Dr. Muhammad, what do you say?
Yeah, sorry.
Select your patients, obviously, but you shouldn't stop the guideline of medical therapy. Go ahead. I'm muted, Dr. Muhammad. اسمعش فيك.
I'm sorry. Am I?
لا واضح نسمع فيك.
Now, go ahead now. Now, yeah.
The guidelines actually specifically added this class of heart failure exactly to point out that these patients should remain on the guideline therapy. That's why they put them as a class. That's the whole point.
Yeah.
Because so the name of trial elapsed me because this has been studied.
Tread heart failure. Tread heart failure.
Exactly. Yeah.
What they did basically
stop.
Heart failure with improved ejection fraction, they withdraw or
became worse.
And 46% relapsed within 6 months. Within 6 months, relapsed. So the guidelines tell you, actually, it's class 1 recommendation that you should maintain them in guideline therapy. Now, you can argue which one, and we do it differently. You can say somebody with tachycardiomyopathy completely back to normal. Would you keep them on everything? I push to keep them on as many as I can. At least a beta blocker and an ARN or ACE. At least minimum. So they have to stay on.
Neurohormone.
Yeah. So I think the answer is there. It's clear. Actually, a lot of people do it wrongly. They stop medication and the people relapse. Even patients with the post-baric cardiomyopathy, name it. Because if you have, I think that my theory of it, that if you have liability for your heart to become weak, then you are prone to have this for you to recur. If you're exposed to the same condition, or if you don't experience the condition, to come back. What do you think,
عبد الغني exactly. No, I totally agree with you دكتور علي.
يا ايمن
الجايد
لحظه، ايمن شوي بس، ايمن بس اعطيني
تفضل.
الاسئله بس، خليك معي ايمن لو سمحت. بنقول يا دكتور محمد, I totally agree with you to a point that when you have a patient who is non-compliant, to see the deterioration in their ejection fraction. I can say my patients who come back with deterioration say you don't take your medications. That's clear indication that they stop their medications, indicating that their heart failure would deteriorate, ejection fraction deteriorates sometimes. And the other thing is we're happy that the heart failure symptoms improved, ejection fraction improved. We say to the patients, don't stop your medications. Why you try to kill yourself? Because you're lucky your symptoms improved. The mortality is very high from heart failure. Don't play with those medications. So the answer, the short answer, don't stop the medications. Continue live until you have more evidence. دكتور أيمن محني.
لا ولا يهمك. هو شوف انا وانا say with you very personal story. طبعا الجايد لاينز both الامريكان واليوروبيان clearly recommend indefinite guidelines for therapy, indefinite, lifelong. And in my practice, unless patient had side effect, they can't afford the medication otherwise. I'll tell you a personal story. My brother had myocarditis, ended up with cardiomyopathy, EF 15%, started on guideline therapy. During follow-up, EF improved to 50%. Then his cardiologist told him, you can't stop the medication. He stopped the medication. 4 months later, EF dropped down to 10%. Alhamdulillah, now he's back on therapy. EF improved to the 40 range. But this is just personal story. I mean, my brother.
Yeah. No, I've seen it many times with our patients.
Stop.
You're right.
So the message, don't stop.
So I actually up titrate medications as high as possible. Continue them lifelong until you have more evidence.
Yeah. Next,
okay, Dr. Ayman.
Next question. Role of serial pro-PNP level in monitoring heart failure. دكتور رجب.
دكتور أيمن answer أنت. جاوب لنا يا دكتور أيمن.
Yeah, this is a good question actually. The European guidelines, they emphasize and recommend not the routine use for pro-PNP, but use it in guidance of management. For example, patient, you're not sure if they're eovolemic or not, you can use it to assess their volume status, if they have change in symptoms. American guidelines, they barely, for diagnosis, there's some rule for pre-discharge to give you outcome, but just as a routine, clearly both guidelines, they stay away from it. But yes, you can still use a serial in terms of follow-up to guide your management. A very strong data, and the higher the pro-PNP, the worse outcome.
No, but don't use it to titrate therapy. There's evidence for that. Don't use it to titrate therapy. It may indicate prognosis. That's the other thing. The higher the PNP, the worse the prognosis, and it helps the diagnosis. The initial diagnosis, first time, if you have shortness of breath, you're not sure. In most patients, not all patients, if it's negative, they're most likely not heart failure. Not all patients, but most likely. If it's positive, then yes, then you titrate. But I would like to hear from Dr. Harari your comment. I'm sure you're geared to say something about it.
Because we probably abuse the use of NT-proBNP in our institute. But there are recommendations that for inpatients, obviously, as you said, to help you diagnose, support to diagnose, support diagnose, but also, as Dr. Ayman said, pre-discharge. And the aim is to get 30% reduction of your admission BNP, NT-proBNP for discharge. That's a guide that your patient getting better, among other things, before you discharge patients. For follow-up, I mean, I use it, and it helps you not only titrate. Actually, it can predict. It can tell you that the patient actually drifting away, even if he tells you I am fine. So guidelines except in support, diagnose, and prognose as far as the guidelines.
European, like I said, European, they clearly mention using it like in terms of CO2 to assess response to treatment, follow up. You start diuresing a patient to assess their volume status. You can use it. It helps you. For example, you go up on diuretic and you start seeing going down. This is give you guidance. But as a routine, no.
But yeah, there's a study was done actually to show that. Maybe Dr. Ali will comment. There's a study done before and showed that if they use it to titrate therapy, it's actually useless. There's a study, I don't remember that, maybe Dr. Harari know, but very important to use it. It's very important blood marker that use it. But as Dr. Muhammad said, we are abusing use it. Should not use it routinely. We use it for certain things. Dr. Ali, you would like to say something about?
Most of the studies على ARNI they were using BMB والBROMB as a يعني زي الاند بوينت زي الماركر for
response
monitoring.
to treatment.
Yes, for monitoring of treatment or response to treatment. يعني معظم الستاديز كان كثير منهم كان use of this markers for follow up patients يعني اكثر حتى من السيمبتومز والساينز والايجكشن فراكشن. Yes.
There's a study, I don't remember specifically for that, done specifically to look for monitoring BMP and follow titrate the therapy based on BMP monitoring. I don't remember the name of that study, but clearly was negative study.
Yes.
Specifically for this question.
عبد الغني, let's see.
أسامة
if he come across أسامة if he come across anything على ال guidelines على الموضوع هذا.
محطين دكتورين من دكتور عبد الغني. أنا بس
أيوة أسامة.
لاحظت اللي بيشتركهم على برو بي ان بي والبي ان بي ان البيشنت اللي هم يستعملوا في الارني في الانتريستو فديما في البي ان بي حيكون هاي معناها ديما السبيسيفيك ماركر هو البرو بي ان بي نوت بي ان بي.
صحيح.
I mean it's marker free modeling.
For the sake of time, I'm gonna move on. Sorry guys, for the sake of time and
Next
just should not be stopped. هذه في question بس خلينا نقولهم بتاع الدكتورة حنيفة.
خلاص انت تشوف الأسئلة توا عبد الغني. خلاص انت تشوف الأسئلة.
شكرا لك أيمن، بارك الله فيك.
اوكي.
ICD indicated for symptomatic heart HFrEF less than 30% ejection fraction. هذه جاوبناها الدكتورة حنيفة. ejection fraction less than 35%. وعلى الثيرابي طبعا according to the is it revascularization post MI or non-ischemic. فهذه بروحها إذا كان فيش revascularization 1 month, post revascularization 3 months, non-ischemic 3 months. Non-ischemic is class 2A, class 1 for ischemic. إن شاء الله يكونوا جاوبنا يا دكتور. ممكن تزيد تعودها لدكتور محمد الحراري الأنسر for this for the ICD indication.
I mean, as you said, I think the question is asymptomatic non-ischemic. So this 3 months therapy. So this is class 2A recommendation rather than class 1 for ischemic. So that's the answer.
No, for ischemic cardiomyopathy, if there is that's CRTD, but for specific ICD only, if they have no left bundle branch block and you have less ejection fraction 31, still class 1, right?
No,
only ICD, not CRTD.
Her question is, she said ICD asymptomatic non-ischemic. So I told her this is class 2A.
Non-ischemic, okay. Non-ischemic is 2A, exactly, yeah. Ischemic, class 1, right? Still class 1, ischemic.
By the way, عبد الغني, في recent article في الجاك, they're talking about the whole concept of prophylactic ICD in those patients, تمام, giving the newer therapy. يعني كل المادة 1 و 2 اللي based on it guidelines recommend ICD for primary prevention. There was no ARNI, there was no inhibitor, up titration emphasis. For now, there's a lot of discussion about actually now risk stratification or using, for example, like MRI to look for fibrosis, like now what you said about ischemic, because they have higher arrhythmogenic burden compared to non-ischemic. But this is something that is evolving. In the future, I think we'll see update on the guidelines based on what we have from the newer medication.
And also, Ayman,
yeah, exactly. No, I'm just gonna say that we see it all the time for the ICD. From when you do interrogation, you don't see the ICD shocks frequently. You see, only select a few patients that we see, like after implantation, say like 100 patients. Only few of them they get ICD shocks. The rest of them actually they have the ICD for several years without any arrhythmia. So that's another thing to support what you said, Ayman.
Thank you.
Sorry, Dr. Muhammad, go ahead.
No. I was just going to say the rule of the 40 days after MI, that might change because we see people actually they improve even after the 40 days. So yeah, 40 days crucial, but after 40 days, still the LV improves. So with good guideline therapy, revascularization, what obviously presumed to happen during the MI, then the LV have a chance to improve. And as you said, people, the one actually they improve, the one have very well established ischemic cardiomyopathy with scarring, ejection fraction less than 35%. Sure, they will continue to need the ICD, I think.
The other thing we should remember is the titration of guideline-directed therapy, because most of them we see like either untreated, undertreated, or they're non-compliant patients. They still have low ejection fraction after that cutoff time, 1 month or 3 months. After even 6 months, sometimes they are not on full therapy. So please remember to add those therapies, up-titrate them to get the best benefit so ejection fraction can improve and we save them from ICD or CRTD. Dr. Ali, do you have any comment? Patient.
Thank you.
في سؤال على الديبيتامين in acute decompensated heart failure without shock. Dr. Ali, do you want to answer this? Role of dobutamine in acute decompensation heart failure?
Yes, I mean, we are using it in this kind of patient, serious patient, decompensated patient, and patient with low blood pressure. I mean, it's recommended to use it, but
without shock.
yes.
They say without shock. Without shock,
Yes.
Dr. Ali. Maybe Dr. Ayman, do you want to comment? Ayman Smear.
I'm not sure what they mean without shock. I'm not sure what they mean without shock. For example, you could have a low cardiac output state with normal blood pressure. But if you have a cold periphery, if the patient is not making good urine, not more than 30 milli per hour, if their mental stat is not, if their lactate is high, if there's venous saturation less than 70%, that's a clear evidence of tissue hyperperfusion using inotrope like dobutamine or mirinon. There's clear support for it, but so don't just use the blood pressure itself. It's a clinical diagnosis. Now, when Dr. Ali mentioned, if it's in shock, the patient, خلاص, you start. This is standard of care. But don't let soft blood pressure fool you. If there's patient clinically have those markers, signs of low cardiac output, you ignore the blood pressure. You treat them. They're not perfusing, as simple as that.
I think they are sometimes overusing it. I think that's what the question is about. Is sometimes if you treat the patient, they don't improve with diuretics. It's normal blood pressure, normal perfusion, no shock. I agree with the question, but they still don't improve, or you want to make them improve quickly. Some people add dobutamine, which is not recommended. It's not. I don't think you should do it unless really there is indication for it. For inotropes in general, there is no mortality benefit from inotropes. It's merely supportive. Dr. Muhammad, do you have any comment?
Muhammad, maybe
محمد حراري.
Muhammad, maybe you comment
خلي
on
محمد
this.
أيمن معلش. أيمن خلي محمد.
بنقول لا.
تفضل دكتور محمد.
Sorry, no, actually the guidelines against the routine use of against the routine use. So as Ayman said, so again, probably somebody did not have time to go into the diagnosis of heart failure, the assessment. It have the the four corners, hyperperfusion, so hypertension is not equivalent to hyperperfusion. You have to, if you have hyperperfusing, then inotropes, of course, you go for.
Totally agree. Exactly. Yeah.
عبد
Any
الغني.
preference for dobutamine or dopamine or dobutamine? Any preference?
Dobutamine.
Or NORAD?
لا, definitely dobutamine. Like عبد الغني, and the point I was trying to say, before you cut me off, Muhammad, maybe this came out from, remember, in the old days when we talk about that renal dose for dobutamine, the 5, increase the diuresis, مش عارف عليه, if you remember those old days.
Some people still use it, yes.
بس يعني follow up trial ودata clearly no benefit of routine. Maybe this way it came from, صح?
Exactly. Yeah.
Yes.
صح exactly. Yeah.
Dopamine for kidneys that doesn't work.
No, it doesn't work. Yeah.
The guidelines against it.
هوني عبد الغني, this is maybe opportunity to advocate for milrinone in Libya. I'm not sure if it's available. لأن it's have a big advantage, especially when you have RV dysfunction or even patient on known on beta blocker dose. you can start it. Dobutamine, and you have to stop the beta blocker. It has a big advantage, milrinone, especially when you have right ventricular dysfunction.
Yeah, it's very interesting that that notion, idea of using inotropes like milrinone and adding the guidelines-directed therapy, small doses, very small doses. It's very challenging idea, but when I was in Canada, we used to use it. Patients with severe LV dysfunction and they think they will improve, you give them small, tiny doses of the guideline-directed therapy one by one, and still keeping them on tiny, small doses of inotropes like milrinone, and you then wean off the milrinone and increase the guideline-directed therapy. Do you do that, Dr. Harari or Dr. Ayman?
Yes. Yeah.
Sorry, I lost Ayman. I didn't hear the question. Ayman.
يا محمد هي الكويشن ان الكومنت انك use inotropes small doses and add the guideline directed therapy one by one, small doses in addition to the inotropes, and then slowly wean off the inotropes and increase the guideline therapies like small dose beta blocker, small dose ACE or ERNI.
If inotropes indicated that we explained, then you put patient inotropes and then you start guideline directed therapy. But you have to be careful. Most of the guideline therapy drop blood pressure, so you can use drugs. Maybe I use ivabradine as an inpatient because it doesn't SGLT inhibitor does not drop your blood pressure. But then yes, and a lot of people will not advocate or don't know what you think, Ayman. Giving beta blocker or somebody on dobutamine to start to initiate it.
But I agree with you, Ayman. We used it before and it works for certain, but you have to be selective. You have to use it very small doses, gently, closely monitoring, and then titrate up or down, whatever works. There's a question about after how long increasing the dose of the medications or up titration. Dr. Ali Nahum?
Yes, as we said that in strong study, they sometimes, they're using the maximum drug recommended by evidence-based recommendation in 2 weeks' time. But the European Society of Cardiology, they recommend that should reach the maximum tolerated dose by patient in about 6 weeks. So within 6 weeks,
and
you should.
The frequency. Like you started them today, and when do you see them again to see if you can increase the dose?
After the discharge, usually they recommend to see them after 1 or 2 weeks, and then in 2 weeks' time you're increasing the dose and follow up your patients and tolerability of the drug doses, and within 6 weeks you should reach to the maximum tolerated dose indicated by the evidence-based recommendation. This have been shown by the strong study and it have been, in 2023 recommendation of European Society of Cardiology.
Yeah, excellent. Yeah, it's very important, especially to titrate. Obviously, patients by patients depends on who will tolerate and what's the dose. Dr. Muhammad, you love I think the iron questions. What's the IV iron versus backed RBCs in patients with low hemoglobin? I think we go with the low ferritin, but can you comment on that?
Neither oral, unless the patient is really anemic, you want to give them RBC because they are anemic. That's another thing. But for the heart failure, we treat iron deficiency. We don't treat the anemia. The more anemic the patient they are, the better the response and the higher the dose you probably need to give. But we treat even patient with hemoglobin up to 15 hemoglobin. All the trial at least 14. I think the iron deficient. With iron deficiency, the definition is very specific. You have to have a serum ferritin less than 100, but that's absolute iron deficiency. And if it's between 100 and 300, with transferrin situation.
What level of ferritin?
Less than 100, that's absolute iron deficiency. You give the intravenous iron. And if they are between 100 and 300 with transferrin saturation less than 20%, that's relative iron deficiency, and they are also indicated. But basically, the iron deficiency without anemia, but the better the response, the higher the dose you give. But it is iron deficiency, it's not anemia, and it is intravenous iron, nothing else. So for a carboxyl dose, I understand available Libya, it's not that expensive, probably cheaper than Europe. So yes, we should screen. It is for symptomatic patients, so you don't give it to somebody who's completely asymptomatic, and they have to ejection fraction. Probably the lower the better, but at least 50% or less. I was going to say, and it is for symptom control and maybe reduction in hospitalization. It's not for mortality, but it does improve quality of life. We see it. With a lot of patients really feel better. Maybe placebo.
Perfect. No mortality benefit, but for symptoms relief, go with ferritin, not hemoglobin. Dr. Ayman, في question about the butamine. It can cause arrhythmia and low blood pressure. How about adding noradrenaline to it?
If the patient in cardiogenic shock, that's the recommended combination. Norepinephrine and butamine, as simple as that. You do inotrope and vasopressor. That's standard of care, not just for cardiogenic shock. It's the same thing for septic shock. Now, the side effect, actually, the butamine has least side effect compared with the dopamine. For example, in terms of arrhythmia, tachycardia, even Miranon, the butamine has the least side effect profile. Blood pressure on a higher dose, yes, can give you hypotension, but it's very safe medication. You start small dose and you up titrate. If blood pressure drop, then you add the norepinephrine, like I said. But normally when they're in shock, you should start with both. Because the inotrope effect of the butamine will increase contractility, but you need the norepinephrine to increase vasoconstriction. You keep the pressure high and improve perfusion. But this is a safe and effective combination.
What's the mean pressure you keep, Dr.
Standard 65.
MAP?
MAP,
exactly.
65, but we know for cardiology, to maintain coronary perfusion, you want your systolic in the 90s.
At least mean 65. Perfect. Dr. Ali Nahum, what's the superiority of furosemide compared to furosemide, especially in furosemide-resistant patients?
Well, a recommendation that furosemide is the best drug for treatment of patient with congestion. But furosemide it have been shown by many studies to improve decongestions. I mean, في البيشنت اللي resistance للفيروزامايد أعتقد.
I agree.
وهو اللي هو up titration وفي اللي يعد ميتالازون. مش عارف what's your experience with that, Dr. Ali, ميتالازون.
No, usually we are not using it here in Libya. I mean, maybe Dr. Muhammad, he have some.
I have used it, but it's very strong. And Dr. Muhammad, what's your comment about the diuretics and adding metalazone, or if they need high dose of furosemide and still in heart failure?
Okay, I think that furosemide, I'm not familiar with it, but I know it's probably similar like to bumetanide. So we talk about the oral use. The oral use, they are better because they're better absorbed than furosemide. But for intravenous, I think furosemide is standard. As far as adding thiazide, this is again is in guidelines. I think Osama mentioned that in the guidelines. So patients do not respond. So when you admit patient to your ward with acute decompensation, we talk about admission, acute or whatever, both. But with acute, you have to monitor them. So you have to monitor your urine output. You have to monitor if you can do the sodium, but at least urine output 100 to 150 ml per hour at least. If they don't respond, then you either increase the dose, if they furosemide, for example, and if you feel you reach a reasonable dose, you add a thiazide-like diuretic. So even if you, Dr. Ali, I don't know if you don't have metalazone, which you use a lot, you can use even bendoflumetazide. You can use that, or hydrochlorothiazide. Any thiazide, if you add it to a loop diuretic, it has a synergistic effect, and it really improves their significantly. And patients do by and large respond to adding thiazide to a loop diuretic when they are not responding to the IV, or even if they are not responding to oral diuretic, they are seeing them in the community. So we use it a lot. We used to, you can use But the response to patient is variable. Some really they have dramatic response. You have to be careful when you add it, especially in the outpatient setting. If I use it outpatient, I use it 2.5 milligram every other day and ask them to come a week later or 2 weeks later just to, and I ask them to monitor the urine, but make sure they don't go into, because they can go into AKI really quickly. But we have patients actually on 5 milligram daily in the community with big dose of diuretics, and they are doing okay. So the response is variable, but they have a big adding a thiazide diuretic. In UK, actually, I used to use bendoflumetazide as add-on before we go into the metalazone. So it still have synergy. It's not as strong as metalazone. So what it is in the guidelines, I think that the trial you mentioned, the ADVOR trial is really a fantastic trial, but and it shows reduction in the duration of admission, which is very important. So adding acetazolamide, the chlorotic in the acute setting really just reduced the weight, but didn't that huge impact. But adding thiazide diuretic to intravenous diuretic, patient don't respond. This is in the guideline.
Yeah, no, thank you. And I might add also in acute decompensation, because of the gut edema, it's always better to add IV diuretic, IV furosemide, because oral, as you mentioned, oral furosemide might not be well absorbed because of the gut edema in acute setting of heart failure. And also can be given as outpatient. When I was in Canada, we used to give it like in the clinic, the heart failure clinic. Patient come to the heart failure clinic. By the way, heart failure clinic is very important. I didn't think Usama commented on that, but it's really, really important. There is strong evidence for that, and Dr. Muhammad can comment on. They can give Lasix IV and monitor the patient. Once they get out of the acute decompensation, put them on the oral if you want to add thiazide or something else. Any comment on the heart failure clinic, Dr. Muhammad?
For the IV as an inpatient, you have to give them IV. You cannot let the patient with acute decompensation failure give them oral. You have to give them IV. IV, and then you add the heart failure is very important. It's not probably the need to discuss it for monitoring, for up titration, for everything. But you can use, if you have facilities, if you have what we call an infusion clinic side, so patient hopefully getting more edemas, not responding to oral, you can give them short diuretics even if they come daily, furosemide daily, IV, and then when they respond, you change oral. But that's need chlorose monitoring. You have to have facility to have a setting where you can put a venflon and you can trust the patient. So you not give the venflon to home, but you give them an injection and let them go home and come back. So compliance also, but it has a role if you're talking about using IV in outpatient setting. You can, and the role of heart failure clinic, nurse-led is crucial. It's in the guidelines as well.
Thank you very much, Dr. Muhammad. For the sake of time, I'm going to just take this last question, and then we'll ask for the expert panel to say last comments, and we'll call it, inshallah. The best rate control in patients with AFib with atrial fibrillation, digoxin or Concor? Dr. Ali Nahum, do you want to answer this last question? AFib, digoxin, Concor.
This is very clear. I mean, it has been mentioned before by Dr. Muhammad Al-Harari that, I mean, because beta blockers is class 1A recommendation, we should start with beta blockers recommended for heart failure patients. And then if maximum tolerated beta blocker dose, atrial fibrillation rate is not controlled, usually we are adding whether digoxin or amiodarone to control heart rate, if we want to control heart rate in this kind of patients. Yes.
Thank you very much, everybody. Thank you for your time. Thank you for the expert panel. Really appreciate the time you talk. Really appreciate your comments. Excellent comments. Excellent talk, Dr. Osama Buzgaya. Just less than 1 minute, please. Every one of you guys, Dr. Ali, Dr. Muhammad, Dr. Ayman, just last comment about the heart failure in general, about the presentation, any recommendations. Dr. Ali Nahum, please.
Thank you, Dr. Abdul Ghani, Dr. Osama Buzgaya, Muhammad Al-Harari, Ayman Smair for this nice comments. اللقاء زي هذا يبين ان زي ما قلنا الجايد لاين is not prescription وفي difference from patient to patient وفيها place for the clinical science. So we should I mean treat our patient according to the situation he is on, but we try to treat him with all evidence-based recommended medication and evidence-based recommended doses. Thank you all.
Thank you very much, Dr. Ali. Dr. Muhammad, your
شكراً.
last comment.
Yeah, it's a great start for your program, Abdul Ghani, and thanks Osama for really taking the time to prepare such a great talk. I mean, guidelines are there to be followed. They are not prescriptive, I agree, but you cannot practice based on your own experience, on your colleague or anecdotal experience. The guidelines there to guide you, so you have to use them. I'm not going to go through the whole what we've gone through today, but there are clear guidelines for HFrEF, for HFmrEF, and Amy's mere point that if you're confused, just use HFnEF and HFrEF. So anybody with normal ejection fraction more than 60%, these are the group where you should just use the HEL2 inhibitors, and I think Finerenone will come into it, maybe GLP inhibitor. And they have anyone with reduced ejection fraction use the 4 pillars. And thank you.
Thank you very much, Dr. Muhammad. Dr. Ayman, your last comment, please.
Thank you, Abdul Ghani, for the invitation. Excellent job, Osama, on summarizing this long document. To the audience, thank you for your time, and thanks for my colleague, the esteemed expert panel. And my advice to everyone listening to us watching this presentation, start heart failure clinic. 10 years ago, we don't have this great medication. This medication works. You see it, it makes patient feel better. I never had patient that when I start medication, they come to me after Entresto, they feel I feel better. After I start SU-20, they still feel better. Now, hopefully with the GBL1 coming, simply pick one day in your clinic, make it for heart failure patient. Teach one of your nurses to be the heart failure nurse with you, and both of you build up your experience, your practice, guidelines available, expert around you, society offering a lot of opportunity, workshop or training. You build up your experience. It's not rocket science, but if you don't practice it, you don't learn. As simple as that. So take advantage of this, but you have to be organized. Pick one day a week or a month. This is when you reschedule your patient for heart failure only. Teach one of your nurses how to deal with them. Teach your patient how to take the medication, how to check their blood pressure. Reach out to them to the phone. You cannot do bi-weekly visit, it's fine. Make a phone call. So you can be creative, do a home visit, because you make difference. This medication saved life. Thank you.
Thank you very much, Dr. Ayman, Dr. Muhammad, Dr. Ali. All the best to all of you, the attendee. Inshallah, I'll see you next time, next month. This journey of the Arab Board Cardiology Fellowship series of lectures will be once a month, every first Friday, inshallah, 7 p.m. Libya time. Inshallah, we'll post the next one. It's all about the guidelines. Don't miss the guidelines. And we'll see you next time, inshallah. Assalamu alaikum wa rahmatullah.
Thank you. السلام عليكم. تصبحوا على خير.
شكرا جزيلا. شكرا عبد الغني، احسنت، بارك الله فيك. شكرا يا